Support for UWTV is provided by the Boeing Employees Credit Union.
Good one.
It's a special day at the Swinomish Reservation near LaConner, Washington. The annual community spring cleanup.
I'm busy right now, I'm jumping.
It's just an opportunity for tribal members to just do a little spring cleaning, and we bring dumpsters in and we have crews go around and just picking up the things that the tribal members put out. And it's something that we've been doing for, gosh, at least 30 years or more now.
Good food.
At lunchtime, everyone takes a break to eat together. It's part of the tradition.
It's a custom in Indian country when you ask people to work that you give them a meal.
The gifts of the land, the gifts of the rain, the gifts of family and friends, that those are the things that you provide. As we gather at the table, we ask your blessing upon the food and upon our conversation.
Doug York is an assistant minister at the Pentecostal church here. Although he's not a member of the tribe, he's very much a part of the community.
Doug is a prayer warrior. He is non-Indian, but he's been accepted into our community because of the wonderful work that he does for our people. You've seen him there today to be with us, to be a part of the community, and he's just a great presence. He's there during good times and bad. You know, he's performed weddings here. He's done funeral services here. He's been here for cultural functions, and so his presence means a lot to our people at Swinomish.
It's important not to be a pastor that's confined by the walls of the building that you're in, but what you are is you're a pastor in the community, and when something happens, it doesn't matter whether or not that family goes to your church. There's a need, and what you do is, as a pastor, you go and you take care of that family.
A year ago, Doug spent a week traveling to 5 reservations in eastern Washington. When he returned, he felt something wasn't right, but assumed he was simply tired from the trip. Then he spiked a fever that lasted 2 weeks, and he knew he had to see a doctor. A blood test showed Doug had a major infection. His most dramatic symptom was an extremely runny nose that just wouldn't stop.
It was like a leaky faucet. That's kind of how it was. And so he told me, he said, well, let's get a handle on the infection, and then we'll get you to a specialist for find out what's going on with the nose. And I thought, I must have a tear duct that's gone bad.
In fact, Doug had a much more serious condition. The liquid coming from his nose was cerebral spinal fluid, or CSF. He also showed signs of meningitis, a potentially life-threatening inflammation of the lining of the brain. His physician referred him to Dr. Greg Davis at the University of Washington Medical Center's Otolaryngology Head and Neck Surgery Center.
After undergoing a CT scan, then we got an MRI scan, and working with our neuroradiologist here, they diagnosed not only 2 skull-base defects, but also 2 encephaloceles, where the brain was actually herniating into his nasal cavity.
Doug York's skull had very little dense bone due to a congenital condition called arachnoid granulation tissue that predisposes people to skull base erosion.
Given that he had 2 areas of dehiscent skull base, or areas of skull base erosion, he was at significant risk for meningitis, or developing a potentially life-threatening condition where the brain becomes infected.
On a Friday night, Dr. Davis called me from wherever he was at, and he said, the good news is you don't have a tumor. And I thought, God, that's great news. I didn't know you were looking for one, but you know, that's that's good news. But he did tell me at that point that that I would have to see the neurosurgeons.
You know, what's interesting when you look at these films is he clearly has encephalocele, or this outpouching of brain that's actually herniated through this defect. And this white, obviously, is spinal fluid all around there, and he's collecting it in the sinus, and a smaller one on the other side. But I think they're both potentially causing his leak. And you can see the defects here on the CAT scan pretty well, too. We can use both CAT scan and MRI intraoperatively with our navigation systems to pinpoint those areas after you get us access with the approach.
I'm very fortunate here at University of Washington Medical Center to have an excellent working relationship with numerous people within the Department of Neurological Surgery. One of those colleagues is Dr. Bob Rastomley. He and I have been working together for quite some time, and it's wonderful to have someone that I trust implicitly to help care for my patients. We looked at Mr. York's CT scans together and came up with a plan of care. And then we both saw Mr. York in clinic and talked to him about the options.
They let me know that what they were doing with me was a bit unique, not the ordinary by any means. But knowing that this is an area that is familiar turf to them gave me a lot of confidence.
Back home, Doug's illness affected the entire Swinomish community.
When we need to call a prayer warrior, he's one of them that is on the speed dial, so to speak, and we get word to him. But when he was down and out, it was a concern. We were really worried. At that point, a lot of tribal members got to pray for him.
We were afraid for the surgery he was going to go through, so we all got around him and really prayed for him. And it was so serene up there. It was heart-touching. It was beautiful.
You want to get the endoscope right in there, and you can actually see inside.
And so Dr. Davis and Dr. Rastomley performed surgery together on Doug York. The location of the CSF leak made the operation somewhat challenging. The openings in his skull base that allowed the brain to push out of the cranial cavity were high up on the sides of Doug's sphenoid sinuses. The endoscopic procedure that the surgeons used involved approaching the area through the nose, but the angle required a particular technique called a trans-pterygopalatine approach.
Our straight instruments don't allow us to make the angles in order to get to the sides of a well-aerated sphenoid sinus like Mr. York has. We have to actually go through an area that contains significant blood vessels as well as significant nerves, and this area is located right behind the maxillary sinus. Behind that is the pterygoid fossa, where some of these vessels and nerves sit, and behind that is the sides of the sphenoid sinus. My main role is to get where we need to go to repair the leak, and that involves a trans-pterygopalatine approach to the sphenoid sinus. That basically allows us to get 3 instruments into the sphenoid sinus so that we can do some functional work. Do you have a smaller?
Those specialized instruments are very fine and very small, designed to fit into this tight surgical space. 3-dimensional image guidance directs the surgeons as they operate. A CT scan shows the location of the instruments throughout the surgery.
Surgery in this era is a lot different from what surgeons were trained to do only 20 years ago. And so we've moved into the digital era and the microsurgical era, and we have small instruments that almost all the surgery is done through the nasal passage without any external incisions. We're guided by CT scans, so we have wonderful imaging so that we can see really the anatomy of an individual patient and anticipate where we need to be surgically so it can be very safe. And we can see beautifully on the screen as we're operating, so we have great optics to work inside the nasal space.
Right there. So now Greg can go down with you. See, now we're going. See, oh man, it's beautiful.
It's a nice shot.
Once a section of brain has herniated into the sinus cavity, that small part is no longer functional. Its loss will not affect the patient in any way, and Dr. Rastomley removes it before he and Dr. Davis repair the skull. In Doug's case, they're using a piece of abdominal fat to plug the hole in his skull base.
Dr. Davis said, you know, they were talking about the patch that they were going to have to put in, and he says, well, we'll use the fat by your belly button. The only scar I have is a 3-inch scar by my belly button. And so that's not bad for brain surgery. And I was telling somebody that today, and they said your brain's in a funny place.
The tissue used to repair the leak will take several days to adhere to the existing tissue within the brain cavity.
And once he recovers from that, the leak is watertight, and he can go back to his normal activities.
Come on in.
And that's what happened. Doug returned to his ministry and hasn't looked back.
Open the eyes of my heart, Lord.
He's got a wonderful job here, and just thank God for him. Wonderful preacher, wonderful prayer warrior.
I want to see you.
Hi.
Hey.
Morning.
Morning.
Dr. Davis.
Most sinus conditions are not as dramatic as what Doug York faced, but ongoing problems can have a significant impact on people's lives. The University of Washington Medical Center's Otolaryngology Head and Neck Surgery Center treats patients with a broad spectrum of concerns. Treatment generally starts with medication, with surgery as an option when necessary.
In addition to treating very complex cases that we see from our 5-state region, we also treat more routine cases. We are happy to see patients who have never had sinus surgery before. And again, we always like to go with a more medical approach to treating their problems and then use surgery when medicine no longer works.
What we offer that's different here, I think, is experience with the more problematic patients. And by problematic, I don't mean behavioral problems. I mean folks who've had 2, 3, 4 operations and are still having symptoms, patients that have developed some complication of surgery, patients who've seen a number of doctors and haven't had a diagnosis emerge. And we see a lot of that.
Physicians here offer treatment for the full range of sinus conditions, from nasal congestion to cancer. Whether the problem is simple or complex, accurate diagnosis and treatment are the core of patient-centered care.
The best way to understand and come to an appropriate diagnosis for a patient is to listen to the patient describe what's going on. Most times there's more than one option to take care of that particular symptom or set of symptoms. There's medical management and there's surgical management. Sometimes there's avoidance if it's mainly an allergic problem. And so the other part of patient-centeredness is to talk to the patient once you've made a diagnosis about the range of options to manage the problem.
Hi.
Hi, can you check in?
The most common reason for patients to seek care is sinusitis. 1 in 7 Americans experiences this condition every year.
Sinusitis comes in 2 basic categories. There's acute sinusitis and there's chronic sinusitis. And acute sinusitis is what most people get. They get a cold or a bad allergy attack. Slowly their sinuses become involved. They get a worsening headache, they get infected looking drainage, and they feel sick. It can occur episodically, but usually patients are feeling normal in between. Chronic sinusitis is when that sort of problem lingers. And instead of completely clearing, the patients develop chronic discharge and low-grade headaches and stuffy nose, and it may last for months to years.
Sinuses are spaces inside the skull. There are 4 sets: maxillary, ethmoid, frontal, and sphenoid. They may be designed to help lighten the weight of the skull and to help with voice resonance, although scientists aren't absolutely sure of their purpose. Mucosa, the tissue that lines the sinuses, can become inflamed due to bacteria, viruses, or allergies, and that inflammation is what causes sinusitis.
If we think of the sinus as a cave with a single small opening at one end of it, if that tissue that lines the sinus swells up, it's going to block off that opening. The sinus is going to continue to make mucus inside the sinus, and that's when it gets impacted and you start to feel the pain and pressure related to sinus infections. And when it lasts for more than 3 months, that's when we call it a chronic sinus infection. And it really becomes problematic when these people are living with this condition, this chronic pain. It's affecting their quality of life, their ability to focus, concentrate. It affects their ability to sleep, and it really just impairs their general well-being.
That's what happened to Leland Bull. His sinuses became so blocked that he could no longer breathe through his nose or smell anything at all.
I didn't really have a lot of pain, but I was no sense of smell, always stuffy, very frustrated. I could never open my nose. And is it life-threatening? Of course it's not life-threatening, but it does have an effect on the quality of life.
Large nasal polyps were the problem. The solution began with a referral to Dr. Ernie Weymuller.
Polyps are pretty common and have two major etiologies. One is just profuse allergic swelling inside the nose. So that's one form of polyp. The other form of polyp, they look pretty much the same, but the other form of polyp comes from chronic blockage of the sinuses from infection. And that group of patients, if you really get the sinus open and the offending sinus or sinuses that has caused the polyp, often the surgery can be truly curative.
After initial treatment with medication failed to alleviate all of Leland's symptoms, he and Dr. Weymuller agreed on surgery. Polyps were removed and the sinuses were opened up to prevent a recurrence. As with Doug York, this was a very delicate endoscopic surgery.
The surgery certainly does require a delicate touch. The boundaries of the sinuses are the eyes and the brain, and the bony walls between the sinuses and the orbit and the brain are delicate bony walls, maybe a little more dense than an eggshell, but not much more. So there is the potential for injury to the orbital structures in the brain. And so one of the major parts of doing this kind of surgery is to be always aware of where you are and what you're doing. And it's actually very safe surgery because we do know where we are and what we're doing.
I can wake up at night and I do breathe comfortably on both nostrils. And I don't wake up at night having to blow my nose. So it's just, to me, it's just total liberation. I mean, it's just in a month. So this is what, 2 months now. It's just, the difference is wonderful.
The big payoff was being able to smell the lavender sachets his wife makes.
It's wonderful. I can smell it. It's so nice. That's what I told the doc I really wanted more than anything else.
In an academic medical center, patients benefit from a combination of shared knowledge and individual expertise.
Being in an academic medical center has always been an advantage for me because of the conversations that go on every day, every week in our meetings, immediate awareness of different research that's going on and also contributing and participating in research. So I feel like this environment has certainly helped me be a more complete physician.
One of the very interesting, challenging, and exciting things about working at University of Washington Medical Center is the complexity of cases that we see. It's extremely nice to have other specialists that are comfortable with dealing with these complex cases. We work with neurosurgery, with neuroradiology, pulmonary medicine, several other disciplines to help diagnose and manage these complex cases. In addition to having competent colleagues, having very high-tech equipment is also necessary. The better we can see during surgery, the smaller our instruments, the less trauma we cause our patients, and the faster they heal and the faster they recover and go home to their families.
Innovative techniques and the latest in technology offer patients successful outcomes. Ongoing research is aimed at continually improving options for patient care.
One very interesting project that we're working on here at University of Washington is looking at olfaction. Now, olfaction is your ability to smell the outside environment. Frequently, patients with chronic sinus infections and other nasal disorders come to me complaining of anosmia or decreased ability to smell.
The odor study, or olfactory dysfunction of rhinosinusitis, works with nasal tissue that would otherwise be discarded during surgery.
There are a number of intranasal agents that we spray into the nose, including nasal decongestions. So we're testing numerous compounds to see how they affect the nasal tissue and ultimately get a sense of what they do in terms of the olfaction.
Other research directly involves patients in testing clinical outcomes. The sinonasal outcomes test, also known as the SNOT-20, asks a series of questions about patient symptoms before and after surgery.
We have several ongoing research studies to objectively assess how patients are doing. One of these studies is actually looking at patients with chronic sinusitis and depression. From prior studies that we've done, we know that about 25% of people who have chronic sinusitis actually have relatively untreated depression at the same time. This research study is looking at whether or not treating those patients' depression is actually also going to indirectly improve their degree of severity of their sinus symptoms.
Diagnosing sinus problems is not always a straightforward process.
A lot of the patients who are referred to us with sinusitis wind up leaving here with a different diagnosis. And so one of our big jobs is trying to sort through and come to an accurate diagnosis based on what the symptoms are for the patient. As an example, facial pain, which is a common symptom of sinusitis, but is also a common symptom of temporomandibular joint syndrome, of stress headaches, of sleep deprivation, and also migraine type headaches.
And sometimes the sinus infection itself is hidden. That was the case with Stephanie Rowe. After losing a tooth, she suffered through 2 failed dental implants before being accurately diagnosed. It was a frustrating time. She was planning her wedding, and no bride wants a front tooth missing.
I had no symptoms other than there was a problem with the implant. And the periodontist had offered to do a 3rd attempt at no charge. And I leaned toward that, but you know, my husband, who kind of knew more than I did, suggested that if you try twice and it doesn't work, there's no point in trying again, that there's got to be something else going on.
A CT scan revealed that the problem was actually in Stephanie's sinus.
And that CT scan showed that she had a very infected maxillary sinusitis, the sinus that's right behind her cheekbone that sat right on top of where they were trying to implant. And so that bone that surrounds that sinus was very inflamed, and clearly without calming down that sinus infection, she wasn't going to improve. So the first step in treating Stephanie was trying to see if we could get it treated with antibiotics. We always try to avoid surgery. Sinus surgery, in my opinion, is generally used when medication no longer works.
Nom, nom, nom.
Stephanie was pregnant with Madeline by the time she was referred to the University of Washington Medical Center, so her treatment plan had to take her pregnancy into consideration.
I saw Dr. Greg Davis, and he was great in kind of analyzing the problem and giving me the different options, and he was great in talking to the OB, also at UW, because I delivered at UW. Ready?
Medical treatment started shortly after Madeline was born with a 3-week course of antibiotics. When that didn't clear up the infection, Stephanie and Dr. Davis agreed that endoscopic sinus surgery would be the best option.
When I looked inside, you could see this black and brown infected tissue. The tissue around it was also inflamed with a lot of tissue swelling. And the whole goal of the surgery was to remove this infected debris. So after the surgery, again using the 70-degree endoscope, looking back into her maxillary sinus, the tissue now is pink and healthy, and you can see that the black and brown infected material has been removed.
It was an outpatient procedure. I was probably in the hospital, I don't know, 6 hours max from in to out. And then had several follow-up visits and took antibiotics, antibiotics that they'd cleared with the OB. Sit. And because I wanted to get pregnant again, we also talked about how long before finishing the series of antibiotics I could try to get pregnant. So it was all helpful with timing and coordinating with nursing a baby and then also wanting to have another baby.
With the infection removed, Stephanie will finally be able to have a successful dental implant as soon as her second baby is born. Again, one of the challenges in treating patients with sinus conditions is diagnosing them appropriately. Other disorders can have very similar symptoms.
Over the past 5 years, our criteria to diagnose chronic sinusitis has actually changed. The criteria are now much more objective. People certainly need to have the symptoms of facial pain, nasal drainage, or congestion, but they don't always have all of those symptoms. The 2 objective pieces of information we use are nasal endoscopy and CT scans. If a patient has inflammation of the sinuses, that's going to get picked up on the CT scan.
Hannah Greig spent years struggling to breathe through her nose.
Oh my gosh, it was awful. I couldn't sleep. I could barely breathe out of my nose, especially having to run as much as I do. I just felt like I could never catch my breath. It was just hard, and my brother said I was like Darth Vader because I always breathe so loud, and everyone makes fun of me because I always breathe with my mouth open. Like.
A college student, Hannah lives in a house with 8 roommates. In those close quarters, her mouth breathing was really noticeable.
Our walls are really thin, so I can basically hear like everything. So when we go on road trips, I've roomed with her before, and she makes like weird noises when she sleeps, or she used to.
I just got fed up with it, and I knew something was wrong, and I had kept telling everyone, I was like, I can't breathe out my nose, and everyone's like, oh, Hannah, come on. But I finally just went to our doctor and got fixed.
She had been suffering for literally years of significant nasal congestion. And a lot of people may think that that's not that big of a problem, not being able to breathe through one side or both sides of your nose. But if you put your finger on the side of your nose and sit like that for a minute or two and try to eat dinner or drink water, you can find out quickly how annoying that is. And it really does affect people's quality of life.
Hannah had a deviated nasal septum. The septum separates the right and left sides of the nasal cavity and is made of cartilage in the front and bone in the back. In some people it can be shifted to one side, either because they're born that way or perhaps due to injury.
When I see a patient with a septal deviation, there are really 2 main treatment options. One option is to try to control any swelling or inflammation of the nasal passageway, and sometimes we can do that with medication.
Hannah tried nasal steroid spray to decrease the inflammation, but it wasn't successful. At that point, she and Dr. Davis talked about the type of surgery that could improve her condition.
We ended up deciding to do a septoplasty. And a septoplasty is a surgery done as an outpatient where it's designed to straighten out the nasal septum. It takes about an hour and a half to complete, and it's all done through the nostrils.
Dr. Davis and his staff and crew were amazing. They were so great. The nurses and the assistants, everyone was wonderful.
Hannah was back in action a couple of days after her surgery.
Hannah's septum was quite deviated, so she had a large room for improvement. And at the conclusion of the surgery, her septum was nice and straight. Unfortunately, she has had a good resolution of her nasal congestion.
I can actually breathe out of my nose, and I can breathe with my mouth closed, which is nice. And I sleep well at night, because I couldn't before, just because I would wake up short of breath and all that. But, I mean, I just can feel, I can breathe.
For more information, to make an appointment, or to refer a patient, contact the University of Washington Medical Center Otolaryngology Head and Neck Surgery Center at 206-598-8896 or go to www.uwent-headneck.org.